Good afternoon and welcome. I'm Stephen Bailey. I'm Editor-in-Chief of Catheterization Cardiovascular Intervention, and I'm joined today by Dr. Davide Capodanno, who, along with senior author Corrado Tamburino, have a manuscript that we've chosen as an editor's choice. And it was chosen as an editor's choice because it addresses one of the really difficult and complex topics in interventional cardiology, unprotected left main, and their manuscript, Objectifying the Impact of Incomplete Revascularization by Repeat Angiographic Risk Assessment with the Residual Syntax Score after Left Main Coronary Percutaneous Interventions. It's a long title. What it basically says, I believe, is that after left main interventions, there is information from how well we revascularize that can tell us how our patient's going to do. So, David, I'm going to have you give us your thoughts on this, and we'll have a little dialogue back and forth about how we could use it clinically. Welcome. Okay.
First of all, thank you very much, Dr. Bailey, for the invitation to share some comments on this study with the reader of catheterization and cardiovascular intervention. Well, for the background of this study, we started from what we have understood from the syntax trial. We now have the 5-year result. And in the specific subset of patients with left main disease, we have seen that there is a clinical equivalence in outcomes, at least in terms of mortality and myocardial infarction, between revascularization by PCI and CABG. CABG suffers from a higher rate of stroke, while PCI has the limitation, the important limitation of a repeat revascularization. We thought that one of the most important differences between the two revascularization strategies is the chance of achieving a complete revascularization after one procedure over the other. With PCI, you can address just the target lesion, basically. With CABG, with the one single graft, you can treat multiple lesions in the same vessel. So this is a very important difference that may have consequences on the rate of complete revascularization. However, in the specific field of left main intervention, the studies that have tried to explore the issue of incompleteness of revascularization after left main treatment are somehow confused by the fact that the definition of incomplete revascularization changes a lot. And in particular, most of these studies have used a binary definition, which means yes or no. Incomplete revascularization may include patients with a CTO on the right coronary artery, but may also include patients with a minor lesion in a small obtuse marginal branch. So putting together all these elements may be not applicable. And so our approach was to study again the issue of incompleteness of revascularization by using the syntax score as a mean to obtain a standardized and objective quantification of the burden of coronary artery disease that you leave untreated after your procedure. And so this idea of the residual syntax score is now quite modern, and many groups are looking at this concept, which I think is very promising.
I think it is important to know that we can use syntax score as a way of communicating both what the risk of patients are prior to a procedure as well as how well we've accomplished the procedure. When you looked at that difference between baseline and residual, the delta in that, maybe you could share with us what information that conveyed, if any.
Yeah, of course. So what we have done in this study was basically to look at our population by residual syntax score. And we considered patients with the residual syntax score of 0, which are patients with complete anatomical revascularization, and look at the patient with the residual syntax score between 0 and 8, which are patients with an acceptable amount of coronary artery disease, which is left untreated after left main PCI. And of course, we also look at the outcomes of patients with a residual syntax score higher than 8. And what we have seen in this study is that there is, of course, a gradient in the number of comorbidities into these three groups. Patients with a high residual syntax score are sicker than patients with complete anatomical revascularization or lower residual syntax score. But they also have a higher baseline syntax score. So these are much more complex patients in which the residual symptom score is high, probably because the interventionalists refuse to treat all the lesion as a consequence of the clinical situation or as a consequence of the angiographic complexity. And what we have seen is that the outcomes of this population may vary. Patients with complete revascularization and patients with low residual symptom score have quite similar outcomes in terms of mortality, cardiac mortality at 2 years, 3% and 4%, which is quite similar. While patients with the high residual symptom score have 19% of cardiac mortality at 2 years. They're very different numbers, and we also found that this is quite similar after adjusting for differences in the study population across the different groups. So the main message is basically that if you leave untreated a certain amount of coronary artery disease, your outcomes may be encouraging compared to complete anatomical revascularization. But if you exceed a certain threshold of coronary artery disease that you don't treat, your outcomes can be really bad.
So it seems like this is, as you point out, great for hypothesis generation, because now we can think about even more questions. One question, I guess, would be, as you're looking at a patient with unprotected left main, can we begin to make predictions of how likely we are to achieve that threshold level, from your study at least, of being able to have a residual score of less than 8? That is, if I'd looked at the anatomy and said, I don't think I can achieve that score of 8, would that potentially influence us to send the patient to bypass as opposed to do a percutaneous revascularization?
Yeah, I definitely agree. And what we have seen in this study is that there is, of course, a correlation between the baseline symptom score and the residual symptom score. So the higher the baseline symptom score is, the higher the chance of leave a high residual symptom score on the table, I would say, on the patient's coronary anatomy. And of course, the point is that these information are not a substitute for the brain and the judgment of the physician, but are a helpful tool in order to discuss with the art team what are the options and what kind of complete revascularization I can offer to this patient. The surgeon may say, okay, my ability to give complete revascularization will lead to a residual symptom score less than 8. The interventionalist, because of a CTO or a complex bifurcation, or because the patient is elderly and cannot afford much contrast, may at the end say, okay, I will leave 10 to 12 to 14 of residual symptom score. So starting from this background, they may have a more complete and comprehensive discussion with the patient and decide for the most appropriate strategy.
Well, thank you so much for talking about your investigation. Again, I think it adds to how I'm going to think about patients now when I approach an unprotected left main, and it's going to make me want to be more careful in assessing my lesions and whether or not I'll be able to revascularize patients. And I think it is something that is going to generate lots of future investigations because of your hypothesis. So this time spent with you and under the leadership of Dr. Tamburino, I think is going to influence patient care, and thank you for spending the time with us.
Thank you for having me.